Hi everyone, welcome to researchmd.com. We got a great presentation today. We've been going with the herpes family on the viruses. So today our topic is varicella zoster virus, HHV-3. We have given presentations on herpes simplex 1, herpes simplex 2. So today we're going to focus on varicella zoster virus, okay? Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency program, transitional residency program. I teach medical students and residents. I'm also director of research. And let's go into our topic. So when you talk about varicella zoster virus, it belongs to human herpes viridae HHV-3. In the children's we always know like chickenpox, and the adult we have to know like zoster virus responsible for chickenpox, and herpes zoster or shingles. And then if you look at the structure of the virus, you got the core, which consists of the dsDNA, the single linear molecule, then you have the capsid, and then between the capsid and the envelope, you got the tegment, and finally you have the envelope. It's the outer layer of the virion composed of altered host membrane and as a unique viral glycoprotein, and they can appear as short spikes on the virus. So today we're just going to focus on shingles or herpes zoster. So epidemiology can occur any age. Previously infected people with the virus, chickenpox. Okay, greater than 95% of the adults in the United States are seropositive for varicella. That means indicated all of them had like some kind of infection in the childhood. And the herpes zoster most common. Herpes zoster is more common in adults greater than 60 years with age-related immunity declining. Okay, incidence, you look at it 1 to 3 per 1,000 person per year in individuals less than 50. Approximately 1/3 of people will contract herpes zoster in their lifetime. Estimated 1 million cases each year in the United States. So remember that 95% of the people as a kid, or they might have an exposure with virus infection, or they might have prior vaccination also. So risk factors, major risk factors, increasing age, we know the immunity go down, so we have to be very careful. Women, it is higher, and whites higher, and person with a family history of herpes zoster also found to be higher risk factors. So the transmission is a reactivation of the herpes zoster is caused by reactivation of the previously transmitted varicella zoster virus, which causes in the childhood, or like you can have a chicken pox, that's like primary infection. And then main routes of transmission is a direct contact with the skin lesions. Skin lesions contain high concentration of zoster, and then risk transmission may be lower in the patient with the primary varicella like chicken pox. Airborne transmission, particularly from patients with the disseminated diseases, also common. So pathogenesis, you have the primary infection, and the varicella zoster virus initially infect in the lymphoid tissue with the CD4 T cells. Infected T cells trafficking to the skin via CCR4 honing, and then localized epithelium in skin epithelial cell later production of cell-free virus, and then viral progeny infects sensory nerve ending in the epithelium. Viral migrates in the neural axon to establish latency in the sensory ganglia, and the latent infection in the ganglia is kept under control by large part by the VCV specific T cell immunity. That's what keep it dormant for a long time, okay, with age and the immunity, and then reactivation because of the immunity decline, and then viral reactivation occurs, could be like several years later. So signs and symptoms on the cutaneous herpes zoster, most common presentation is herpes zoster. We got dermatoma. It's kind of go by each dermatome. Does not cross the midline. Remember that. Thoracic, cranial, lumbar, cervical dermatomes are most frequently. So which one is most common? Thoracic, cranial, lumbar, and cervical dermatomes are most common. Rash is preceded by prodromal symptoms like itching and tingling sensation. We get a burning sensation. Some patients kind of report this happens. If you ask like the most common prodromal is kind of like burning sensation in the area. And herpes zoster, there's something, a serious issue like which is called herpes zoster ophthalmicus. Okay, what happened in that? You got the first division of the trigeminal nerve, ophthalmic nerve involved. It can spread the entire eye, leading to complications, stromal or neurotrophic keratitis, uveitis, scleritis, episcleritis, retinal necrosis. You can have permanent vision loss. It can present with ophthalmic symptoms and no rashes also. So blistering rashes will be produced by painful neurological prodromes. So very careful about herpes zoster ophthalmicus. So characteristics of prodrome, we talk about paresthesia like itching, tingling, and allodynia or hyperesthesia, cutaneous episodic episode. Prodrome sometimes could be like 1 to 5 days before the presentation. You can have rash. Let's look at the classification of rash. You can have macules or papules that resolve into vesicles or pustules, cloud, and crust over 7 to 10 days. And the new lesion may arise in subsequent days, filling the dermatome. So diagnosis, you can mainly, everything is kind of clinical diagnosis, but if you want like, check, you can do PCR, you can direct fluorescent antibody testing, you can do viral culture, CSF fluid analysis also needed when there's like a CNS involvement. Okay, so let's look at all the tests. You got the possible, and the first one, the PCR test, polymerase chain, very good sensitivity and specificity, 94 to like 100%. Okay, and then you got next test is the direct immunofluorescence. You can do very good sensitivity also, 82%, and specificity is 76%. So when you talk about the treatment, antiretroviral therapy commonly used, you can use, if immunocompetent patient presenting within 72 hours of rash onset, and if they're like greater than 50 years, and non-truncal involvement or moderate severe symptom, patient with a disseminated zoster or complication including ophthalmic or central nervous system involvement, and all immunocompromised, you need to do antiviral treatment. Okay, you can do valcyclovir, acyclovir, famiciclovir. The doses are given right here. If you're hospital admission and CNS involvement, obviously the IV acyclovir is available. And what are the complications people usually develop? You can have like post-herpetic neuralgia, okay, which can like defined as persistent 3 months beyond rash duration. Pain may be intermittent, associated with and can be like burning, electrical shock like pain, allodynia, and severe enough to, patient have like a lot of complications and unable to sleep and activities of daily living problem. Usually post-herpetic neuralgia is like people greater than 50 years old, increasing age, large ophthalmic involvement, and presence of greater prodrome severity. Okay, so the other complication, you can have scarring, hyperpigmentation, you can have bacterial superinfection, also very common. Neurological combos, already talk about herpes zoster, ophthalmic with the trigeminal nerve. You get Ramsay-Hunter syndrome with the deafness, myelopathy, aseptic meningitis, acute chronic encephalitis, cerebellitis, and polyneuropathy, polyradiculitis, cranial nerve palsies, and Bell's palsy also. So many neurological complications are there. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Thank you.